So this is an interesting study, not just because I designed it, but this is our first industry-sponsored study that actually we developed here at Downstate in Kings County. So this is a phase 3 trial. What is a phase 3 trial in pharmaceutical terms? Phase 1 is where you give an experimental drug to normal, healthy people who could do this. Phase 2 is you give it to people with the disease, but you give it at varying dosages to find the dosage range that's probably most effective. And a phase 3 is to look for efficacy in patients who are suffering from the disease. So this is a phase 3 double-blind, placebo-controlled, multi-center clinical trial for the safety and efficacy of Icatibant, which is a bradykinin antagonist, receptor antagonist, for ACE-induced angioedema in adults. So this was a big study done over a few years. I'm going to show you the study. So, the financial disclosure, they didn't pay me for this. You have to say that when we do one of these talks. Although they did send me around the world to present this. So ACE inhibitors, as you know, are increasing in prescriptions because the indications have expanded, not only for hypertension, but for CHF, even for diabetic nephropathy with a normal GFR, people are giving ACE inhibitors. And about 1 out of 150 patients will get angioedema. About a third of them will end up in the emergency department. And some of them are going to need a surgical airway. So this is an iatrogenic, very serious disease that you would expect a good treatment for. So there is a disease that's similar to this, which is hereditary angioedema. Hereditary angioedema we know is bradykinin mediated, and Icatibant, or the generic, or the brand name Firazyr by Shire, is approved for hereditary angioedema. So it made sense, since hereditary angioedema and ACE-induced angioedema look alike and probably are bradykinin mediated, to try Icatibant, which is a bradykinin receptor antagonist for ACE-induced angioedema. So a study was done and published in the New England Journal in 2015, the ACEi study. This was a study done in Germany in 27 patients. This is a kind of strange study because it was only done in Caucasian patients where ACE-induced angioedema is a disease of African Americans. And we believe because African Americans have higher baseline bradykinin levels, and when you block ACE, their bradykinin levels increase and they're more prone to angioedema. They only look at 27 patients. They randomized the 2 groups, which is the Icatibant versus standard therapy, and they found there was a significant benefit in the Icatibant group. They looked at patient-recorded responses, like on a Likert scale, do you feel better? Is the edema getting better? And then they scoped all the patients. So they had time to onset of relief when the patients were starting to feel better, and time to complete resolution of edema by laryngoscopy. And there was a significant benefit for the Icatibant group. And this got published in the New England Journal of Medicine, but the FDA and Shire didn't believe the results because it was a very small study, only done in Caucasians, and kind of a funky outcome. So they asked a whole bunch of emergency medicine doctors, I know one of them, and immunologists and ENT surgeons to develop a new study. And that's what the study we're going to talk about today. So the phase 3 study. So the inclusion criteria is they had to have symptoms less than 12 hours. They had to hit the ED and be given the drug less than 12 hours from onset of symptoms. And you could give them anything you want, antihistamines, corticosteroids, epinephrine, because we've shown that it doesn't work. But we were afraid that since this was kind of the standard of care, we didn't want to limit people to what they were going to use. So everyone could get any drug they wanted, and they were randomized into the Icatibant group or to a placebo group. They had to have moderate to severe, and we're going to define moderate and severe angioedema in a minute. Patients who were excluded if they had angioedema from other reasons. Most likely, if they had urticaria, this was not ACE-induced. Urticaria is an allergic, histamine-related disease, and probably you should give corticosteroids and antihistamines and maybe epinephrine if they have urticaria and angioedema. But we excluded those because we were just interested in the ACE-induced. And if they had severe respiratory distress, and this exclusion was very important because it had to be a consented study, so the patients had to have a pretty good airway and weren't on the way to the operating room to get a surgical airway. So we excluded the really severe ones. So we randomized 1-to-1. They got 30 milligrams sub-Q. They were centrally randomized by a computer somewhere in Shire country, in the Shire, as we call it. And we stratified the patients to increase the number of patients who had moderate and severe. So we tried to push the patients into the moderate severe group, and also we tried to push the patients more into African American patients, because that was who got the disease, and we're more interested in those. The syringes were, labeled. We couldn't tell who it was concealed, who got the drug and who didn't get the drug. And because Icatibant causes a small amount of bradykinin release when you give it locally at the site, they get an erythematous patch. We actually covered the area. The doctors who looked at the airway, judged the outcome of the study, were blinded to where they got the shot and to any injection site reaction. So how did we determine severity? So a whole bunch of us sat together in a room, and we decided that difficulty breathing, difficulty swallowing, tongue swelling, and change in voice were the 4 big symptoms. We graded the symptoms from 1 to 4. And actually then we tested this about a whole bunch of, before you guys got here, we sent pictures and symptoms out to a whole bunch of ER doctors, ENT surgeons, and immunologists to see if they agreed with our severity by description of the cases. And so they did, and the inter-rater reliability was actually 0.8. It was actually pretty good. And this paper is going to be published soon. The discharge criteria, and this was the discharge criteria was used as the outcome variable. To be discharged and to say that there was actually an effect of the drug, they had to have no difficulty breathing at the time of discharge, no difficulty swallowing, although they could have a mild voice change and mild tongue swelling. So these are the severe, moderate to severe patients. So the patients that we commonly see, just the lip swelling, wouldn't be included in this study. They had to have at least moderate tongue swelling, change in voice, difficulty swallowing, difficulty breathing, or change in voice. So then the outcome was the time till they met discharge criteria. So it was the time in minutes and hours to meet the discharge criteria. We would plan to do subgroup analysis of every variable we could imagine, but this was pre-planned, so it was okay. And we looked at adverse events, mostly the skin reaction. So this study the sample size was 120, 60 patients in each group. It took 31 centers to screen 147 patients over a year and a half. 26 were excluded, 120 randomized. About 60 and 61 patients in both groups got either the placebo or the drug. This is the comparison of the two groups, the intervention, the Icatibant group, and the placebo group, and you can see that we did have over 70% in moderate, but only 26 to 30% in the severe. So it was definitely skewed to moderate. We didn't have as much severe, and definitely skewed, as we had planned, to African American populations. About 70% of the patients were African American. But we planned that. So this is the Kaplan-Meier graph. Let me just tell you what a Kaplan-Meier graph is. There's a x-axis, which is the observation time. It's the time that you observe the patient, and the y-axis is the time that they met the discharge criteria, right? The percentage of patients meeting the discharge criteria at any one time. The red dotted line is the placebo. The blue solid line is the Icatibant. And even without any statistics, you could tell that there's no difference in the two groups, right? You don't even need the statistics. Actually, the p-value was like 0.63, not statistically significant. So there was no difference in the time to meet discharge criteria between the intervention, the Icatibant, versus the placebo. Didn't work. Didn't work. Just to my confirmation. Didn't work. So there was some mild ejection, like we had think. About 2/3 of the patient did have an injection site reaction, but we knew that from the hereditary angioedema study. And there was no serious adverse effects. So, Icatibant, it didn't work. The subgroups, it didn't work. When we divided up in subgroups, it didn't work. One group was not better than the other. And our study did not confirm the prior study, the MA study. So we were wondering about this. So this is all the investigators. So when you do these multi-center studies, this is what you need. There's a lot of people. To do 147 screenings, it took 31 centers. It took a year and a half. And this is just for 147 patients. So why do you think it didn't work? What do you think? What are the possibilities?
Different mechanism.
So it may be hereditary angioedema is significantly different than ACE-induced angioedema. And phenotypically, it does look different. Hereditary angioedema is a disease almost exclusively of Caucasians, where I said ACE-induced was a disease of almost exclusively African Americans. So there's some debate anyway. Also, what it looks like, hereditary angioedema, you've probably never seen a case, presents with abdominal pain, nausea, and vomiting, where ACE-induced angioedema is an upper airway phenomenon, lips and face swelling. So that maybe it's not bradykinin, right? What are the other possibilities? The other possibilities are that the bradykinin half-life is like 25 to 30 seconds. So the time that they're sick is not due to bradykinin levels, it's due to the levels of the ACE inhibitor. And since we allowed people 12 hours from symptom onset to get to the EAP to get to the drug, probably in the placebo group and in the treatment group, the ACE level was already dropping, so that the bradykinin levels were dropping. So if you inhibited a level that was very low, it didn't make a difference. And the placebo group's levels were very low. The other reason I think it didn't work is we excluded, for practical reasons, the sickest patients with probably the highest bradykinin levels. So I think that's what happened. So I think we waited too long, and we took out the sick patients. So actually, the drug company came to us to redesign the study as an exception from informed consent study, where we would look at mostly the severe patients. And we would, instead of time to meet the discharge criteria, to how many patients we could prevent getting a surgical airway. Yes?
Why did you choose 12 hours? What was the...
We didn't know at the beginning. That was just what, because of feasibility, we thought we wouldn't get enough patients if we waited less than 12 hours. But I think in the future, now that we have this data, we're going to make it then 6 hours or 4 hours. And we're going to try to skew the data to the more severe patients. Any questions?
Do you have any idea how many patients you missed in the severe group?
Well, no. Because we screened them. I would say when we looked at the data, about 25% of the patients we had missed that we screened were missed because of severe. So we would have a lot more patients, but it was just not feasible because it was consent required. But if we can convince the FDA to do this without consent, and I think the safety data is very clear. It's a very safe drug now with hereditary angioedema in thousands of patients, and now this study and the MACE study with Icatibant for ACE-induced angioedema, no serious adverse events. We're trying to convince the FDA to do it without consent. Although this will be the first actually pharmaceutical company inspired study that is going to be EFIC. Most of the EFIC studies are NIH. Any other questions? Well, thank you very much.